Hello and welcome to this episode of the Brain Train channel. Before I move on to the recording with our guest on this episode, I would be very grateful if you can firstly, number one, subscribe. That helps alert you to new content when it's released. Two, like the video. I've been reliably informed by YouTubers that liking videos helps with algorithms, whatever that means, and ultimately can get this helpful content pushed out there and get the information out to others who may find this helpful or are affected by acquired brain injury. So I appreciate everyone who watch on YouTube says that, but I can say on this occasion it is obviously for good, charitable and educational reasons. So at the end of each episode, I will have a signpost to other pods, vlogs and websites and contents from around the brain injury world, which you can access and hopefully gain more from. So without further ado, I hope you find this episode helpful and informative, and please do leave comments and feedback in the box below. Today's episode with Dr Koseen Ford. She's going to talk a little bit about herself and what she does as a consultant clinical neuropsychologist. So rather than me try and explain it, well, sort of introduce Koseen and how she's come to where she is today, I'm going to quickly pass over to Koseen so she can give us a little bit about her story and how she's come to help people with acquired brain injuries. So over to you, Koseen.
Right, thank you very much. I've been a clinical neuropsychologist working in this field for over 30 years. My interest in this field started when I was an undergraduate and I undertook some voluntary work experience, which you need to do to get into this field. And it was working with learning difficulties and also brain injured individuals. And what struck me was that they looked normal on the outside. And when you started to work with them, with their families, you then understood, the term, the hidden epidemic, the walking wounded. And that's where my interest started. And then from there, I then specialised in every placement at university in neuro, including Broadmoor. We've got a lot of brain injured patients there, but that's another story. And then in the NHS, I worked with the Leeds head injury team, and we were so fortunate that we had some time to train in Israel. Sadly, quite a few acquired brain injury cases there, and also in Denmark, which was the opposite. It's the more rehabilitation, absolutely brilliant rehab facilities there. So we could then bring it back to the UK and try to implement it in the NHS. I've also worked in the spinal injuries unit, a regional spinal injuries unit, and that was fascinating because over a third of the patients in a year I did a research on had a missed traumatic brain injury. I mean, it just follows. If you've fallen off a roof and you've broken your back, you may have landed on your head as well. And then that was another aspect of the brain injury coming in. And so ever since then, I've been really very focused on this. And now my interest is in brain injuries in cultures, individuals where English isn't the first language. How can we assess these clients and patients and then implement strategies, take into consideration their issues? So there's a lot more for me to do yet.
Yeah, and I think you touched upon a very good topic, which the two of us are quite familiar with in terms of the cultural differences in brain injury. Perhaps we probably could do a whole episode on that itself, maybe in the future. So I think the sort of purpose of today's call really was obviously for you to just explain in sort of simple terms, what is a neuropsychologist and the things to sort of expect with that. So I think my first sort of question to you, Koseen, would be, what is a neuropsychologist?
Okay, a neuropsychologist is a practitioner, a specialist who is concerned about the relationship between the brain and behavior. Right, that's the definition. What it really means is that it's someone who's got a very detailed understanding of the functioning of the brain and how that translates into everyday skills. So which parts of the brain are responsible for which aspect of daily life. And if there's anything going wrong in the brain, how will that translate in day-to-day life? So it's the brain and behavior. And behavior includes your thinking, mental processes, emotions, and how you behave. But I can discuss that in detail later on.
Yeah, no, good. And I think if anyone who's sort of new to acquired brain injury, as you know, the sort of premise of this sort of program, if you like, is to help those, particularly the sort of loved ones around that injured individual, to understand the various disciplines and therapists that come into this when they're getting the rehabilitation. So I think that the general public would sort of more or less know what a psychologist is, but what is the sort of subtle differences, if you like, between a neuropsychologist and a psychologist, if you like?
A psychologist, usually called a clinical psychologist, focuses on emotions of whatever cause.
Yeah.
It could be trauma, it could be life crisis, whereas a neuropsychologist focuses on emotional, behavioral, and mental cognitive issues that have been cause related to a brain injury or an illness to the brain. So it's related to the brain.
Yeah.
That's the difference.
Yeah.
More specialized.
Yeah. So it's looking about the interplay between behavior and function,
Yeah.
and how that sort of links back to whether that's organic or not. And that's often if viewers don't already know, Dr. Ford does do some medico-legal work, does expert reports for the courts, and that's often an issue that comes up into organic versus non-organic, and differentiate, well, shall we say, untangling it all. And
I think, just to interrupt, and the specialism of neuropsychologists is that they can administer specialist tests that have been developed to assess different functions of the brain, such as attention, memory, problem solving, language, and we administer these, and then we analyze the results to see if there are any changes that are due to a organic brain injury illness, or is it psychological, or is there another reason? And that's a particular expertise of neuropsychologists, which psychologists don't necessarily have.
yes. Well, perhaps we can probably come back to that, because it is a good point. I mean, you have sort of touched upon this already, Koseen, but can you sort of describe the typical problems individuals, sort of, newly injured survivors, if you like, might face from a cognitive perspective? So as an example, being able to carry out their typical day-to-day stuff, so remembering where things are, to the change behavior, and how can those sort of subtle changes can be debilitating if left untreated?
Yeah. I think the first thing to stress is the word cognitive. A lot of my patients don't understand this. They'll say, what is cognitive? And I just say, it's all the skills you need when you're thinking and doing things. So it's sort of the building blocks. You've got to start off with concentration, attention, memory, learning, and then being able to process things, adjusting what you're doing when things around you have changed. So in real life, the problems that brain injured patients will normally report is, starting with concentration, is, I can't answer the phone and write the message at the same time. That sort of multitasking. I'm in having a conversation with somebody, but after a while, I can't keep it up. I just can't focus anymore. I'm at work, I'm a manager. Before the brain injury, I was organized, I could prioritize, I had everything in order. Now, everything's piling up, I'm overwhelmed, I just can't cope. Relatives will say, it's really frustrating. We keep telling him things again and again, and he just doesn't remember. Or he keeps repeating himself. Things like prompting, you need to prompt them. I think you need to have a shower. I think going to make a sandwich, you need some structure and planning, and cooking a complex Sunday roast. You'd be surprised how hard it is when you've had a brain injury, the steps that are needed to do that. Things like I was in the middle of doing something and phone rang, I got distracted and I forgot what I was supposed to do.
Yeah.
It can cause problems at work. I'm in a meeting and everyone's firing questions at me and I can't think quickly and I can't remember and I feel so stupid. And then they feel quite lacking in confidence, then they get anxious, then we have psychological issues and that make the cognitive processes even worse. And Ewan, the most important issue for me is to take home message is fatigue.
Yeah.
Brain injury, especially a severe one, even a mild one, the long-term problems usually are fatigue. The brain just isn't as efficient as it used to be, and it just uses so much more energy. It's like a car that before the brain injury could run on 40 miles per gallon, and now it's 12, and he needs to keep refilling, and it gets tired. And that's the most important thing. So you've got all these issues, and then you're expected to go to work and work full time, but you're getting tired and you've got problems with concentration, problems with memory, and you're struggling. And people are making comments, especially your boss, and you're worrying, if I lose my job, how am I going to pay the bills? We also get it in relationships. At the family, partners will say, do you know, he's changed, his personality has changed. It's like walking on eggshells. The slightest thing, and he'll lose his temper. It's like being with Jekyll and Hyde, because the parts of the brain that control emotions, that filter what you're going to say, what you're going to do, isn't working very well. So, for example, what mum said to me, I took my son to Tesco's, and he just blurted out, "Look at that man, he's so fat and bald," and it was so embarrassing. Or he'll just start talking to anybody, there's no filter, and people are looking and thinking, are you mad? And they're embarrassing. There are so many other examples that I could give you that the family in particular will report, because sometimes the brain injured individual doesn't realize they've got a problem or how bad the problem is.
Yeah.
So, inside can be an issue. There's also impulsivity, going online, buying things again and again that you don't need, saying things and not realizing the consequences of what you're saying, that you're actually hurting somebody. Somebody once said to me that my world is very black and white. Before my brain injury, it was full of color. Now it's black or white. I can't think in other ways. It's concrete and it has to be my way. I can't understand it when other people are saying things that don't fit my world.
Yeah.
So you can imagine the difficulties this would cause in a relationship at home, social leisure life, and particularly at work.
Yeah. No, I think you've given a whole host of examples, and it sort of led me to start thinking about the phrase neuroplasticity that gets thrown about a bit in our line of work, and how each individual can just ultimately be affected differently. I mean, as you'll know, there's some people who can have quite severe brain injuries and make better recoveries than others, whereas some have more sort of moderate to sort of mild brain injuries, and the impact can be different. And just tagging on to that, those who were sort of previously high function individuals, they might have had quite cognitive demanding jobs, and even if it's sort of a slight brain injury, if you like, it can sort of really knock them off that pedestal. So talking about that and sort of the brain's natural recovery, and you touched upon fatigue as well. Can you sort of explain how neuroplasticity fits into all of that, and sort of explain it in a way that Joe public can understand?
I mean, it's generally accepted that the brain can take up to 3 years to recover following a brain injury. And then after that, it's sort of it plateaus. That's as good as it gets. It's variable recovery. I found that if somebody's been very fit at the time of the injury, that really assists in recovery. But it also depends on where they've got to function after the 3 years recovery. And my experience that if you've got to go somewhere, if you're working in an area that's really demanding, such as I've had patients who've been head of science, I've had solicitors, advocates, teachers, accountants that have to think quickly, fast, problem solve under pressure situations, and working long hours.
Yeah.
That's sustaining that mental effort. These kind of professionals, these kind of individuals really struggle. It's not to say that someone who's doing something that isn't cognitive demanding won't struggle. They will, but they can adjust for it.
Yeah.
If one of my patients is a physics teacher, and he said, I'm teaching A-level students, and they'll ask me a really complicated question, and I have to go back to my office and think about it and answer it half an hour later. And they look at me and think, "What's wrong with you, sir?" And he said, "I'm so demoralized by that." So the plasticity, I do work with children as well. There's a school of thought that says that when you have a brain injury much younger, certain parts of the brain that aren't damaged can take over. But there's another school of thought that says that doesn't really happen. So plasticity, it's up in the air at the moment. Some parts of the brain do take over, others don't. Yeah.
Okay. That's
I mean, the way I usually explain this to patients is that it's as if the wiring of your brain has been damaged, and the brain's trying to find alternative wiring, alternative routes to get somewhere, and it just takes much longer, and it's not as efficient.
Is that where the cognitive fatigue comes in then? Because the brain's sort of working hard to create those pathways again, and that's where the fatigue sets in.
Yeah, and it's doing it not quickly as well. It's using a lot more oxygen, and it's taking much longer. Yeah,
that's good. Okay. Well, I think before we sort of move on in terms of how the neuropsychologists can help with that recovery. Obviously, when you first see a patient, you'll carry out a battery of tests to see where they're functioning at. I always sort of warn clients when they're having assessments with a neuropsychologist, just you're going to be tired after these tests, so make sure you've got someone to drive you home or something like that. So obviously you can't go into the detail of the tests, you can't do that, but can you sort of briefly explain what is sort of involved in that initial assessment? What are you looking for? What are the tests, what are the tests trying to get at?
Well, I always start off with, I usually insist that the patient comes with a relative or a carer, someone who can also provide additional information, because the individual can be quite anxious, or they've got problems with memory. So I want to get as much information as possible. I usually start off by trying to minimize their anxiety, because I'll say, I haven't slept all night, I was really worried what you were going to say, what you're going to do. And it's just try to create a relaxing atmosphere, and just to minimize their anxiety, and explain that I just want to find out what their strengths are, what their weaknesses are, to get a picture of any changes in their functioning. And I need to hear what they say. I need to hear what their relatives are saying. So that's the qualitative aspect. And all through that interview, you're watching how they speak, you're looking at their mannerisms. Just a simple question of how was your journey here will tell you a lot about what's happening. And you are then preparing for how you will assess them. If they've got difficulty with word finding, you'll know you can't do certain tests. if their vision isn't very good, or they've got paralysis in one hand. So you're assessing them from the moment go, but in a way that is unobtrusive, and it's making them feel relaxed. Then I usually tell them I'm going to administer some tests. It'll feel like being back at school, and then they usually relax because these are standardized tests. And I also tell them that if you need a break, we'll have a break. Just tell me when it's getting too much. So after the interview, I then administer the tests. The tests are to assess different parts of their thinking process, their attention, concentration, memory, skills of judgment, organizing, planning, behavioral control. I also administer questionnaires to look at mood. I also ask the relatives to fill in a questionnaire of how they are functioning now compared to before. The whole aim of my assessment is to try to understand the areas of strengths and weaknesses the individual's presenting with, and compare them to what they were like before. And it's really difficult because we don't really know what they were like before. So you ask their educational history, employment history. The relatives will be important in telling you the personality has changed. They'll tell you all the issues. And sometimes they get very upset because it's really hard for them that this isn't the man that they'd married. This isn't their child. And you will give them time to grieve, because that's quite important. But it's to get a picture of the areas that will need to be focused on in treatment, in rehabilitation with the team. And everyone's different. Some people make a pretty good recovery. Some people make some recovery and some don't recover a great deal. And we have to just monitor this. And then after the 3 years, help them to adjust and then manage their issues. And that's the most important thing, to get a realistic expectation of what they can do, and then how we can get a quality of life to work around their issues. And the most important thing is look at your patient and think, what is it that makes them tick? Because that's what's going to then guide you with their rehab. And I'll discuss that a bit later.
I think one point that came to my mind, which again often comes up, is that patients and clients can sort of perform well in the standardized testings because it's in a quiet room, and they can sort of sit and focus. Yeah. And they might sort of perform, where you would expect them. But as you say, part of your role as a neuropsychologist is to look at, okay, they are doing that in the standardized test, but what are they like in the real world? Which is why you want to speak to a family member, get them through these questionnaires, really get a holistic view. Because I think the sort of clinical term, the frontal lobe paradox, is that the which I like throwing out there, but I think that
so that means that if a lot of brain injured individuals, when there's quiet, minimal noise, minimal distraction, lots of structure, they know what to do, they're given prompts, they're allowed time, they can function really well. But in the real world, when the children are screaming, the phone's ringing, there's traffic, there's lots of stimuli bombarding the brain, they can't filter it out, and then they struggle to focus, think, come to decisions. And that's why we call it the frontal lobe paradox, that the individual can do really well in a clinical setting, but in real life it can be a totally different situation. So that's why the relatives are very important, because they can also give you lots of examples of their difficulties, that they will sit in the room and say, I don't do that. I've actually had some relatives on their mobile phone taking a video of the issues and using that as a feedback, and also showing me the difficulties, helping develop insight. But it's got to be the relative's phone because of GDPR, not mine.
Yeah. I mean, I'm just trying to think of that as a lawyer, whether that's a good thing or a bad thing. But I think just sort of moving on in terms of you've again touched upon a lot of what the neuropsychologist does in terms of the assessment and a little bit of that thereafter. Why do you, what would you, yeah, let me just sort of put this in the right way. Why would you say neuropsychologists are an important component of the brain injury rehab team? Why do you think you are essential to that?
We're essential because we advise on management and rehabilitation training for cognitive issues, behavioral issues, emotional issues. So, for example, the OT will be trying to teach dressing, but if the memory is impaired, we can then advise the OT and the physio when they're teaching exercises, teach them in a certain way that will help retention and help the patient in remembering what you're telling them to do. So you neuropsychologists are part of a team. That's the ideal world. And you then advise the other professionals in the hospital setting, in rehabilitation wards, and also in the community. Yeah. And so it's like we all fit in. It's like a jigsaw puzzle. The physio, OT, speech language therapist, and the neuropsychologist and the family, and then we work together setting goals. So our job is to focus very much on the cognitive and the emotional issues that will be barriers for physio, OT, speech and language therapy.
Yeah, okay. I think often that a thing that comes up with clients of ours, that they often feel a little bit out of control. There's all these individuals sort of suggesting and recommending what they need to do and this, that, and the other. What would your response be to that? Because normally I just sort of say, remember, this is your life. This is, you're the boss in that. I mean, would you sort of concur with that sort of view in that? Because that's often an issue, isn't it? After they've had such a traumatic event, they just feel out of control.
Yeah. I usually say it's about quality of life. Yeah. Look at the difficulties you've got, and the team is here to help you to get a quality of life, and also to help them get a work-life balance. Because sometimes the individuals just want to get straight back to work, straight back to what life was like, and they're struggling, and they'll be working long hours, and they'll come home and they've got nothing left for the family, their social life, and they're having to sleep all weekend just to catch up. And it's work-life balance and saying, let's get you a quality of life. You deserve this. So sort of reframing it in a way that it's about them.
Yeah. So on that vein then, what should a patient or client expect from a good neuropsychologist then?
A good neuropsychologist is somebody who has a good bedside manner.
Yes.
Yeah, and you don't, it literally is, you look at the individual, I do home visits or they come on the ward, you start asking them about them. Who are they? What makes them tick? I'm a motorcyclist, I'm a rugby player, I'm a football, I have learned so much about football and rugby with all the brain education that work in. And when you start speaking the client's language, I know all there is to know about motorbikes. I've even learned the offside rule now because I've had to talk to my patient.
Explain it to me because I don't know anymore.
Apparently it changes. It changes. When you start talking the patient's language, they are going to engage with you. You're not just this clinician who's just test bashing, who is in an ivory tower world, who doesn't know what it's like for someone who was really a keen footballer and now will never go back. So you then say, okay, what you can do is let's do something low level. I had one patient, we got him back to being a kit man. He could then do the kit, carry the kits, and just do small chunks of organizing and have breaks, but it was still part of that football environment. Yeah. I had another man who was he loved motorbikes, but he couldn't because of his brain injury. And so he got a workshop built in his garage so he could tinker around with assistance. because he had epilepsy. So we had his wife or a support worker, but he could do his hobby. So you've got to understand what motivates them, what makes them tick, try to understand them. And then when you come to devise a rehabilitation, try to get them back to functioning in some sort of level, you're using their personality, they're using what's important to them. Yeah. So if it was me, I love interior decorating and fashion, so I'll be at Harvey Nicks with my support worker.
You need quite a bit of budget there, wouldn't you, Koseen? I think just going back to what you mentioned about your experiences right at the very beginning in terms of Israel, working abroad, and I suppose sort of broadening your horizons in that sense. From those experiences, what have you, can you say what you've adopted from those experiences to sort of make you the neuropsychologist you are? What have you took from those experiences?
I think with Israel, it was get rehabilitation started soon. The sooner you get rehab, the sooner you get the team involved, and it increases the likelihood of successful outcome. I'm not saying you're going to be completely 100% recovered, but the adjustment issues are much better. So get in there soon. In Israel, they were in the wards, they had the whole team, and then they would follow them into the community. So that was powerful. In Denmark, they're very well funded, and it's the educational element, getting back into work and educating the employers, yeah, and in the community. So it's the long-term educational, employment, vocational issues. And it's funding, but also needs the expertise, and it's the team, and you have to work as a team, because the brain doesn't work in one single specialism. It uses all different skills, and that's why as a rehabilitation we need all different skills as a team to get the person back to some form of quality of life. What else have I learned? I've learned about expectations, realistic expectations. I've learned about it's important to do research, because you're going to go to the NHS managers, and in your field, you've got to explain why you need X amount of funding for this rehab, because it does work, it does help, it's necessary. So I've learned about research as well.
Well, I think the sort of the things you're talking about there, you sound quite passionate about it. It leads nicely on to my next question, which was, what do you enjoy about being a neuropsychologist? What, are there any sort of stories that you want to share? You mentioned some of the patients that you've had in terms of, the motorcycle.
I really, there's lots of things I enjoy about neuropsychology, but the one I really enjoy is the analysis. The parents or the family will come and say, he's got XYZ symptoms, what's going on? Or the patient will say, am I going mad? So after they've been discharged from the ward, I'll see them in outpatients, I will assess them, and then I will show them the results of my testing that says, this part of your results are not as good as they should be. And do you know why? Because it's that part of the brain that was damaged when you fell down the ladders or when you were knocked down. And it's that mapping and the analysis and feeding back that you're not going mad, this is real, and now what are we going to do about it? Yeah, giving them that sense of hope and a sense of achievement of we're going to go forwards now together. So I really enjoy that. Not all patients that I assess have organic brain injuries, and it's then informing them there's really nothing wrong with your brain, which is great news. You're just very anxious, or you're just depressed, or if you stop taking XY medication, you're having side effects. So it's giving that feedback of what's really going on. Yeah. So I enjoy that. I enjoy the success stories of those individuals who accept that life is different, it's changed, and they're not 100%, and they're learning to manage their issues. And they've got a new journey, a new life, and they've got new goals. So the footballer, I had a GP who had a brain injury, couldn't go back to working face to face, but what he did do was go back and work in a GP practice, but looking at the test results, the blood tests, doing things slowly on his own, so he could make lots of notes. So he was still doing something part-time in a field that he'd worked in for a long time, and he felt good about himself. I think one of the biggest compliments I ever had was this young girl who I'd assessed when she was about 5. She'd fallen down in a playground, had a brain injury, and I'd been following her all through the years. And she did her A-levels, and she came out and she got really good grades. And she said, I'm going to train to be a neuropsychologist. So I thought, wow, well done. So yeah, so that I didn't really coerce her into it at all, but that was the feedback. When they learn from their brain injury and then try and do something that makes their life worthwhile and others, that sort of philosophical aspect of the brain injury. Yeah. And I think also teaching, just educating people who don't really understand. The brain injury patients, most of them look okay, but they really are not.
Yeah. Which is where the sort of walking wounded
yeah.
comes in. I just wanted to sort of one final thing for me, just working back a little bit, because we've touched upon this neuroplasticity concept. We've talked about having early intervention to sort of aid that natural recovery. In terms of that early intervention, is that because a lot of it is about strategies and coping whilst the brain naturally recovers? And are these coping strategies more or less designed to keep at bay that emotional dysregulation so that you can feel more confident? Because is it the case that, if you're really anxious and if the bad mood kicks in, will that, probably stating the obvious, but will that have a detrimental impact in terms of the natural recovery process? Is that why it's so important to get that early intervention in?
Yes, it is. It really is, because what you're doing is you're preventing problems. You're preventing escalation, and then things get out of hand, and you're preventing a development of a vicious cycle.
Yeah.
Yeah. So you're helping the recovery process, but you're making sure things don't get so bad that the individual's partner's left him, divorce is coming, he's got the sack, kids have just, life is just decimated. That's what happens, what can happen if we don't get in soon and educate, and it's preventative action in place.
Yeah, I think that's an important part, isn't it? Not just educating the individual, but the family as well, in terms of what to expect and how to cope with that. I mean, I think that's been quite a big topic of conversation of the last few years, really, in terms of that brain injury education for the family network, because they are often the ones, well, I suppose the sort of de facto therapists.
Yeah, and I think one of the other issues is the community long-term follow-up. NHS social services, finances are really limited, and if I had a magic wand, that's where I would focus on. When you've been discharged and the family are left alone to deal with the issues, the long-term follow-up and the sort of scaffolding that's needed, and that's an issue that I think we need to focus on. And I think in medical legal settings, if there's funding, that's great. We can get that going. Sometimes, well, often there isn't the funding. So, I work with Headway, I work with charities, we do talks, we try to train volunteers so that there's somebody that can accompany the brain injured person to go out, get out of the house, not feel so isolated. So the long-term follow-up in the community is something that really needs looking into, and always will.
Yeah, no, I know from my own experience with Headway Rotherham, the big thing about it is that social interaction, because they take a massive knock to their confidence. They don't feel comfortable going out, but having that sort of community and building that camaraderie between them, it does do wonders. So yeah, the community aspects are huge.
But then I also get the issue sometimes, a lot of my brain injury patients are young males, and they'll say, I don't want to go to headway. I'm not that knocked off, and they want to normalize it. So it's trying to find another venue in the community that makes them feel normalish within the context of their brain injury. The gym is great. It makes them feel that they're normal again. But it's important that if they've got epilepsy, there's someone there, there's someone monitoring, making sure they're pacing themselves and not to overdo it. So that's one of the things that I'm trying to work with Headways, is to try to have different kinds of headways for people who need the community support, but in a way that fits their view, and the others that want it with that really nice cup of tea and cake and talk about it with other families and partners. So different levels of support.
Yes, you need a variety of events that can cater for the different individuals. Absolutely.
And I'll tell you something else that's really come at sports using. I've had patients who just will not entertain the word brain injury rehabilitation. No. And then what we usually say is, well, we've got this sports coach and they're really brain injury physiotherapy trained. And so, let's do sports activities, and then the OT can use that. So we're doing sort of sporting activities that just don't use the word rehab. And then it's again engaging with the individual and just trying to get them to see the goals that they can achieve.
You often have to do that sort of disguise the rehab, camouflage it to sort of engage individuals.
Sometimes I do, especially the very fixated, stubborn, what I know best. And years down the line, they come back and say, yeah, you were right. And you say, well, right, let's get on with it. Now then, what are we going to do about it? And then they'll say, I do like X, Y, and Z. And then we use sports and gym and then just bring in the brain injury. And
It can be a long process, can't it?
Yeah. I just want when I work in the spine injuries unit, a lot of the time, if you told them you were the clinical neuropsychologist, they didn't want to speak to you. They'd say, no, go and see someone else. They need you. They're not right there. So what I would do is I just walk around with my mug, and I wouldn't tell them who I was. And I just start talking to them about their injuries. If it was a brain injury, spine injury, their motorbikes, things they liked. And then before they knew it, they were talking to you and they were engaged. And then I would tell them I was a neuropsychologist. And it was too late.
Yeah.
So sometimes it's about trying to engage with them.
Yeah, that's great. Well, I don't think there's much more I need to ask you, Koseen. I think we've been quite thorough there in terms of an introduction to the role and the world of a neuropsychologist. So I think that sort of wraps up. And thank you for your time today, Koseen. I think that'd be a massive help, and I've no doubt we'll get you on again in future to talk about some more specific things. So that's great. Thank you very much.
My pleasure. Thank you.